So my name is Kanan Patel, and I am a pediatric dietitian from Children's Healthcare of Atlanta, and I have been with my team for the last 17 years, and probably will retire at some point with the same team, you know. And I'm here with Angel Marie Jones, and she has been with the CF team for the last 6 years. Sorry. I will let Angel introduce herself then. Okay, so without further ado, we don't have any disclosures to make. We have 3 lovely speakers, Erin, Susan, and Steph, and they have wonderful presentations for you. Our objectives are, you should be able to state at least 3 practical practice strategies for weight-inclusive care while practicing weight-centric model. Review and discuss nutrition guidelines for pregnant and lactating women with cystic fibrosis, and discuss body image along with emotional, physical, and mental impact of cystic fibrosis in LGBTQ plus people seeking gender-affirming care. I wanted to show you this QR code that Terry had mentioned so that you can give us a feedback for 2025, and we'll put that again at the end. So let's get to our first speaker, Erin. Okay. So Erin is a pediatric registered dietitian, certified diabetes care and education specialist, an eating disorder dietitian with 20 years of experience. For the past decade, she has been with Baylor Scott and White McLean Children's Specialty Clinic in Temple, Texas, where she provides dedicated support to children and families managing eating disorders, endocrine conditions, and cystic fibrosis. Erin provides a comprehensive approach that supports patients and families while fostering lifelong health habits in the areas of nutrition and activity. Welcome, Erin.
Good morning. All right, if I run long, it's going to be Angel's fault because she's the timekeeper here. You're good. I'm actually really happy to the start of this because we're going to be talking about somewhat of a mind shift. And as human beings, we just really, really struggle. Like, I don't know, how many of you are just really upset that we had to move rooms? It's just thrown off your plan. Okay. We'll embrace the discomfort because that's where we're going. No, I'm just kidding. Before I do objectives and things, I wanted to start off with this reflection. So if you have a piece of paper handy, I do actually want to encourage you to take this moment of practice. Again, we've all traveled a far probably distance. We slept in a bed that is not our own. We may not be feeling grateful for much at this point in time. And so as I go through disclosures and things, just taking this to heart and thinking through some of these things as preparation. I don't have any disclosures. For those of you who came to the Weight Neutral Talk last year, you may have noticed this slide. I don't know how many of you are familiar with these kinds of disclosures, but each of us has a story. Each of us has a perspective. And so when I come up and speak to you, I am coming with several unlearned privileges that shape my experience. And that's something that I have to, 1, state to you, and 2, continue to actively unlearn. One that I added this year was time. I don't know that we always think about time as a privilege, but those of you who are giving talks or have ever given talks, that is a big commitment. To have that space and ability automatically shapes the person's perspective. So I added that one. Oh, sorry, hold on. I can't see my notes. Is there a way to see my speaker notes? There's no presenter. Oh, okay. This got scary. Woohoo! All right, my mind shift is okay. back in, I think it was September of last year, Body Trust actually did a session on, now I don't remember the title because I had it written down in my notes, but basically in the age of highly effective modulator therapy, Body Trust is a evidence-based, trauma-informed approach, and so I wanted to pull this up, one, because they had given a presentation before, but also this just sets the tone. Whenever you come into a patient's room, right, are they living in an affirming society? What are they bringing into that space that we're trying to add our medical nutrition therapy onto? These are our objectives. If you're listening to this presentation going, did I miss something? Like the foundational part of this seems to be missing. Yes, this is kind of like part 3. And so there's QR codes for all of the previous presentations that give you a whole lot more of the evidence base behind weight neutral care, as well as the QR code for the resources. So please take pictures, please use that as a resource. So we are at a crossroads, right? How many of us have kind of heard that for like the past 3 years since we came back from COVID? Historically, nutritional outcomes and health have been tied to body size. And so that's just what we had to do to help our patients to survive, which resulted in a lot of pressure towards feeding, right? We had to maximize nutrition. We were laser focused on body size as a direct outcome. And I want to say when things change, it doesn't mean we were wrong. I think that's the instinct. It's like, oh, we were wrong back there. No, we weren't wrong. There was a correlation. We had to go where the evidence led us, but we are also operating in a new place. So it's not an or, it's an and, okay? So when we're looking at weight loss as an intervention, I want to make sure that we're really, really clear on the evidence. This QR code will take you to the Weight and Healthcare newsletter by Reagan Chastain. If you are not familiar, it is a excellent resource. That is actually where I got this slide. So I don't know if anyone's familiar with Stunkard at all. It looked at research with weight loss from the 1920s to the 1950s. And basically at that point, they were documenting it is not effective. Y'all, we're sitting at 100 years of literature that tells us pretty much anyone can change their body in the short term. What does the short term look like? About a year, okay? About 95% of individuals are going to regain the weight that they lost at 2 to 5 years. And ultimately, up to 66% of people will regain more weight than they lost. As we go through this talk, I am not against weight loss. I am against providing an intervention that fails most people and actually causes a majority to weigh more than they did when they started the process. That is my concern as we're looking at the evidence. I don't know how many of you are familiar with the clinical practice guidelines for the treatment of childhood overweight and obesity. I took this straight out of this document. When we're talking to families about weight loss, do you think they're picturing this outcome for their kids, that for the rest of their lives, their weight will cycle up and down? This isn't stopping a treatment and starting a treatment. This means from the age of 2, we're counting calories, we're restricting, we're pushing exercise, and even with all of those interventions, the expectation from the clinical care guidelines is that these kids' weights will cycle. I wish I had time to go into all of the evidence for weight cycling, but it is associated with all of the things that are also weight-related conditions. So increase in diabetes, heart attack, heart disease, all of those kinds of things. Hopefully I've driven home this point so far. Our weight does not equal health, and even more so, it's not an indication of a person's value or worth. Neither is health. Again, this is very contrary to what we have established in just society at this time. in a clinic, so I'm going to take you into a clinic space, working with a family as we're talking about health. Most people have been instructed, oh, thank you. Oh, yay.
so much.
All right, I have notes now. I don't know where to sit. Oh, y'all are so kind. Okay. So health is complex, obviously, right? Many of the times as we're counseling, I wish I could do this, but in clinic, a lot of times I will cover up environment, medical care, social circumstances, and genetics and biology, where we just have individual behavior. Because that's the way we communicate in the room, right? Like, you do this, it's going to result in this, right? That's hard. Can you guarantee that if someone is exercising 150 minutes a week that they will never ever develop diabetes? I can't make that promise, right? Can you guarantee that someone who is eating more fruits and vegetables is going to lose weight? I can't control anybody's weight, but I can help people to adapt more healthy behaviors into their life and in their practice. Okay. One of the big challenges we run into is healthism, which makes a lot of money, right? There's a lot of capital in healthism. So it places health as the priority for a human being and forms the basis for discrimination if health is not the sole focus of someone's health. So as we're looking at this, diagram, I may ask a family, like, out of 100%, what percent do you think each one of these factors impacts your health, right? And then I will actually ask, which one do you think has the greatest impact on your health if we're talking about percentages? Does anyone want to shout out a guess? Social circumstances? Anybody? Environment, genetics, yep, absolutely. So I typically then go into, whoops, what just happened there? Okay, I'll go into this slide, oops, okay. So if we look at the breakdown, it's actually a combination. So the greatest part is the social circumstances or the socioeconomic factors. Really interesting that 50% of this can actually be traced back to zip code. Right? Like, you could have a person with similar demographics living in one zip code and another, and their health is going to be vastly different. Are we having these conversations in clinic? Like, that's a hard conversation to have, but as we're talking about health behaviors and body size, this is 50%, right? When we look at health behaviors, that's going to include tobacco use, diet and exercise, alcohol, and sexual activity. So of that 30%, we have to kind of even further divide that out as we're looking at it. Now, I know the big concern is if I have this conversation with my patients, they won't do anything, right? That's our fear. We want to use that fear, right, of some sort of outcome to motivate behavior change. Since the 90s, research has shown that fear is not an effective long-term motivator. You may get behaviors, but those behaviors are going to be more out of self-punishment, right? I have to do this to change my body versus self-care. How many of us keep up things that are punishing to ourselves? Not long, right? I'm struggling with way too much technology up here. Okay. So as we're looking at the model of all of the things that impact health, I really like to come back to Maslow's hierarchy of needs. I know you may be like, whoa, we are dietitians, not social workers. Why are you pulling this up? I want us to look at this and specifically think about how CF impacts each one of these layers, but also how the body you live in, right, dependent on body size, how you experience this, right? Physiological, okay, are we able to fit in spaces, right? I mean, that's a legitimate challenge for some people. Will I sit in a chair and my rear end will fit in that, okay? Feeling safe, again, both for CF and for body size. I don't know why it is okay just to make comments or even just stare at someone when they're coughing. Sorry, we had a story down here. Social affection, just love and belonging. Again, both with a chronic illness and body size. On and on to the very top of self-actualization, which I would propose we do not have an existing framework for someone with a chronic illness or a large body to essentially be all they can be, and that is wrong on so many levels. Bringing it specifically to nutrition and what you can do in the clinic, this is Ellen Satter's hierarchy of food needs. So it models, to some extent, Maslow's hierarchy of needs. So at the base, we're just trying to get enough food. If we think about CF in terms of kind of a historical perspective, oops, did it not go? Thank you. I have this in front of the slide. You want to hold it? Okay. Y'all are so kind. Okay. All right. We're pros up here. From a historical perspective on CF, it was hard just to get enough food into patients, right? That was our goal. Coming alongside, we need to do more butter, we need to do more calories, whatever you have to do to get enough food into yourself or into your child. Similarly, if we go onto a diet, all of a sudden our body is physiologically struggling to get enough food. So essentially we're going from one challenge to get enough food to another challenge to get enough food. And that 180 is just very, very disorienting. This could also be someone living on a tight budget, food insecurity, even how many of us struggle to just take time to eat, right? Like we've gone all day long, right? That also factors in to not being able to get enough food. Once we're able to get enough food, which is so hard, as you're working in clinic, you could be working months and years with trying to get someone to just eat enough food for various reasons. We can move on to acceptable food. At this level, you have access, so you're getting enough, and so you can actually move on to what is acceptable based on your own definition. Now, I want to put a word of caution here. As someone's eating more regularly and eating acceptable things, there is a high risk of taking someone's acceptable food and planting a seed that it is not acceptable. So once we start to remove their acceptable foods, guess where we drop back down to? We're not able to get enough. And I know it's our instinct, right? We're here and there eating this or that. I want to jump in, right? I want to tell them the right way. We're going to get to where that education can come in on this pyramid. Reliable, so we've got ongoing access to appetizing food, and at this place we're able to plan. Have you ever been in clinic where someone's like, I just really struggle with making a meal plan and sticking to it? Well, that's because we're probably not at a level where we're able to match that at this point. Asking questions to find out, are we getting enough? Like, are they dieting? Are they intermittent fasting? Not going there on that debate. I'm just saying it can be a factor as someone is trying to plan to feed themselves. Next, just having good tasting food. Appetite can become a little bit more discerning at that time. I don't know if you've ever found a plan that's working, and as you're eating, you're like, okay, I'm kind of getting tired of eating the same things over and over again, which kind of then naturally drives you to look on to kind of other options that you can add in. Novel, again, with plenty of time eating those favorite foods, we're going to seek out new things. I think this is also super applicable as we're talking about picky eaters. Research shows that you have to expose a child to a new food 15 to 20 times before they may try it. I would just say human beings, right? If we're at this level, it can take lots of time and exposure, and not everyone's gonna like every single food, and that's okay. It's awesome. We have lots of variety. We're not gonna get scurvy just because we don't eat spinach, right? At the very, very top, we have instrumental food. So at this level, we are able to eat or avoid eating certain things for specific physical, intellectual, or spiritual outcomes. So each one of these levels builds on to each other. Looking at all of this, where would you say medical nutrition therapy comes in? What's the place where we can begin with medical nutrition? Anybody? It's actually an instrumental. I know, it's pretty crazy, right? Because we're not trained to do this, right? We're not trained to work with people who are pre-contemplative. We're not trained to work with people who don't have the foundational skills, but so many of us, for so many reasons, are struggling. When we try to provide education at a lower level, you hear a lot of like, I fell off the wagon, kind of thing with what I'm trying to do. A lot of times I'll use a house analogy. So if we're building a house, right, we start with the foundation and build up. When we start with what we're eating, that's the roof of the house. All of this else is underneath is the foundation, okay? If we start building a house with a roof, it's not gonna work, right? How do I figure out where someone is, right? That's cool. I can see this triangle. I see you kind of point out these details. How do I know where somebody is? I'm not going to read all of these questions, but these are a good resource to go to. If you're familiar with Ellen Satter's work, I took most of these questions from a binder of handouts that's Feeding in Primary Care. So I didn't just come up with these questions, and there's many more that you may think of that would be applicable to your clinic. As we're looking in pediatrics, we feel like it's hard feeding ourselves. Try feeding other independent bodies, right? And then you have 3 kids, all with different preferences and different needs. How do we make that work in one household without their parents losing it? And also making sure the parents are able to eat enough food and take time for themselves as well. So as we're asking maybe even a question, because I know we're all thinking, I have 5 minutes, how am I doing this, right? So maybe I have one question, right? I'm gonna come in with this one question. We want to listen to understand. How hard is that, right? I'm listening and I'm thinking, okay, I know this, I could say that, right? But listening to understand, not to fix. This is hard. If you haven't done the PEP training, I feel like every time I present, I'm plugging PEP. It's such a great resource that the foundation provides to us. Ask permission to provide education. Again, I know that sounds really silly, that's my job. That's what I'm supposed to do. What do I do if I don't provide education? The fact that you're there and assessing and listening, motivational interviewing is an intervention. Okay, I don't think we stop to think that it's only an intervention if I'm telling them to eat more or eat less or add this in, but motivational interviewing is an intervention, okay? The no, I love the no's. I wish I could do a whole presentation when a patient's answer is no, because there's so much depth there. And again, if their answer is no, right, if you had shared all of your amazing education with them, they didn't want to hear it in the first place, right? That's a really hard place to be, I know. We want to provide education that meets the individual where they are. And again, there's a challenge there because you could see, if you would just ... right? But they're really struggling with what their body looks like, and taking time to eat enough food is really, really challenging for them. So this is a skill in and of itself to try to provide that education that meets people where they are. Ultimately, our number one goal is trying to reduce barriers to take care of ourselves and our families with food. What does that look like at a very, very high, I'm clicking on the wrong thing. There we go, nope. There we go. What does that look like on a very, very high level? I'm not gonna read this slide to you, But it's very basic on routine and all of the things that we're talking about. It heavily leans into trust. Who can tell best how full or empty any one of our stomachs are, right? But do we trust that? Is it okay to trust that, right? For a long time, that wasn't something we could trust within CF. We had to push past, right? It makes sense that we're coming with some experiences or trauma related to that. And also meeting our families where they are and extending grace, because whenever we try to push ourselves beyond what feels genuinely comfortable, it slows our growth in any area. What we're ultimately working on is a model. This is an evidence-based feeding model called eating competence. So we're focusing on attitudes and behaviors, not food selection. There's 4 components that you can see here. Ellen Satter actually offers a training for a validated tool where you can actually measure someone's eating competence. If you are interested in doing that, it's really helpful to know where a patient is, but also if you're in pediatrics, working with a family, if a parent has very, very low eating competence, that impacts their ability to feed their child. We're striking this balance between permission and discipline, okay? There are many internally regulated models of eating. I think probably the most popular one is intuitive eating. This is not meant to cast any, dispersion on intuitive eating. I just feel like there's a lot of depth to work from within the eating competence model and strategies to help families there. Even though we're not necessarily specifically talking about what foods are consumed, this is what the research has to say for individuals who are eating competent, which is so interesting because this is what we're aiming for, right? As we're working with patients, this is what we want for them to have as outcomes. When we're looking at children, again, all the outcomes that we are looking for with our other interventions that can come with risk of harm, the weight cycling, like the slides that we saw earlier. I know this says for children, but honestly, this is how we would want to feed ourselves, right? This goes back to taking care of our bodies with food, regardless of body size. I don't know if you've ever thought about how when we treat different bodies differently, that in and of itself produces a whole different line. Like if I have someone with high blood pressure and I tell them to lose weight versus I have someone else with high blood pressure that I tell to consume a low sodium diet and be active, right? There's going to be different outcomes because we're providing different education. And then we go back and say, well, the person with the higher weight, that's why they're having negative outcomes. It's because of the body size. We don't back it up to go, wait, I provided a different intervention to this person. Ultimately, that slide shouldn't be on there. No. Okay, well, there's one circle ahead of things. We're looking at habits, right? As we're talking, we're trying to remove those barriers to build habits. I know we've been trained that there is a correlation, okay? There is absolutely a correlation, but correlation is not causation when it comes to body size. I really like this study that shows us, when we have 0 of these habits, what our health hazard ratio is. But even if we just add one, so maybe I'm not smoking, or maybe I'm drinking alcohol in moderation, right? Just one habit, and you can see how that ratio drops. I know this says diabetes. I didn't forget what what session I am in, but I actually came across this last week, and since apparently I have a love for triangles, I thought that this would be really helpful. So we kind of look at it right and left as well as building up from the base. Ultimately, we're looking at how can we help our patients engage in renewable and sustainable thoughts, behaviors, and systems. How are we promoting this within our clinics. I know conversations about weight are scary and hard. As we're talking about what gets in the way, body size definitely gets in the way, right? That idea that if my body looks like this, I must do that. If my body size looks like this, I'm assuming that this person does all of these things because of how their body looks. This may not be a practice in your clinic, but asking permission to review the weight and the growth chart, I think, is just a really, really simple way to start, okay? Again, when the no comes, there's so much to learn in the no. It can really open up those questions, not, well, why did you say no? Like, I appreciate you, sharing that. Is there a concern or something? Like, see how you can kind of flow into that. If their answer is yes, weight is a neutral data point, okay? Temperature is taken because if it's outside of a, specific range, we know something's going on, right? We're not going to just give you Tylenol to treat your temperature, right? In the same way, if we're seeing shifts with weight, we want to build a foundation to have that conversation in clinic. Not that you have necessarily done anything, but that I noticed this shift. You have to work really hard to build weight as a neutral data point, but I would encourage you to advocate for that. It was really great to see this in clinic with one of my teenage patients because we've had a lot of conversations and her weight was down. And I was like, hey, from previous conversations, you've kind of shared that whenever your weight goes down, I should ask you about how your enzymes are going. And she's like, yeah, not really taking them. I'm like, okay, cool. You want to talk about that today? No, not really. I'm like, okay, well, we've built enough understanding and it wasn't like, oh, your weight's down and there's a huge panic that disengages us from relationship. When it deviates, that's where we want to be curious. And again, going back to the idea when we look at that big circle, that there's so many things at play there. Another really great question, just kind of how we feel about our body size. Lots of questions. I love questions. It just helps you to kind of see where people are. Pick your favorite one. Come up with your own based on your patient population. Ultimately, when we have our answers, we want to reflect and respond. Again, not listening to fix, right? It's so common when someone expresses a body concern like, oh, well, you're beautiful. You can be in a large body and beautiful. That doesn't change the fact that it's really hard to live in society in a larger body. Acknowledging that bodies come in all different shapes and sizes, right? There's ultra marathon runners who live in larger bodies than me. There are people who do absolutely no physical activity and maybe have really poor quality diets that live in really, really small bodies. We want to be very intentional with our language, creating that safe space. Hopefully this presentation to this point has helped give you some tools around how to create that safe space. And ultimately we're focusing on behaviors, right? If they come in and they weigh their weights up, but they've been, playing with a recreational soccer league, awesome. I am so glad that you were playing soccer. It seems like it's something that you really, really enjoy. I'm not concerned about your body at this point in time. Tell me more about soccer. Okay, I have a minute left on collaborating with weight-centric providers. This is for sure challenging. The first thing I want to bring up is we're all here to help, okay? As we learn about this, if you may notice, I'm super passionate, okay? And I can get a little, aggressive is probably the right word, but it should not be aggressive because it automatically tunes people out. We are all there to help. No one is intending harm, okay? So that's a really good first foundational step as you're having these conversations. We want to model the language that we would hope our doctors will use. So any of you who are parents, right, you model the behavior in hopes that they will start to adapt it. It takes a long time. We want to be patient. We want to be encouraging. We want to share the patient's perspective, right? We've done all of this time. We know where they are on maybe the social determinants of health, Maslow's hierarchy of needs, the food hierarchy. So what they need to do and where they are is a huge mix match, and we can come in to support them with just kindness and compassion to help support them along the way, always bringing focus back to behaviors, advocating for our patients, and then if you have enough rapport, these are some really, really hard questions to ask. Probably my favorite, well, favorite's a weird word, but do I believe that people in larger bodies shouldn't be stigmatized, but that fatness or obesity should be eradicated? That's hard. So you may be like, I don't mind, but then ultimately I'm working towards making all of my patients smaller. That is weight bias. Here's our key takeaways. The QR code here is a link to Medical Students for Size Inclusivity. They have so many resources there, and they're actually starting a weight inclusive organization for medical providers as well. Okay. Thank you, guys.
Thank you, Erin. That was a lovely presentation, and you did it with grace, with multiple technologies. And thank you to Angel for holding that up. Yes. I'm sure her arm is numb by now. All right, so because we started a little late, we'll give about 5 minutes for questions, and then if we have more time at the end, then we'll get more questions. So anybody have a question?
Well, I had one. Can you hear me? Okay. How do I work with a patient who needs medical nutrition therapy, but they are struggling to get enough food on the hierarchy of food needs?
Yeah, that's actually a really good question. I tried to kind of allude to that as we were talking. We come in with our own agenda, right? Our expectation of kind of where we want a patient to be. So it would come back to kind of where they're at, even though maybe I'd want to work on more variety or something else. I would really kind of spend time trying to understand what their daily routine is like and trying to carve out times to eat. Even if that's starting with like one intentional time a day, or they eat once, but maybe we can add a second time in, and just kind of really giving ourselves some grace. I don't know if anybody else does this. Like, I'm not a good dietitian. I'm not a good enough dietitian because I didn't get through all of this information. That's what I would do.
Okay, well, I'll ask one more. What if my patient or parents of my patient don't want weight neutral?
Ooh, that is a very good one. It's very individual dependent for sure, right? If they're really, really kind of staunch and you're like, I can't go there, we're always going back to behaviors, right? That's the thing that's so interesting, whether you are doing weight inclusive care or weight neutral care or weight centric care, right? We're still talking about eating variety, eating regularly, moving bodies. So we can still talk about all of those behaviors, okay? You can, if it doesn't feel inauthentic, kind of use the language that even you feel like is stigmatizing, but meet them where they're at. And I promise at some point, there will be an opportunity to bring weight inclusive care up, because they'll be doing all of the things and expressing frustration that they're not seeing the results that they would have hoped for. And so then you can kind of come in and maybe gently plant a seed or start that conversation.
Oh, hi. Yes, please. Oh, okay. I can't reach
Oh
that.
my gosh.
So I love how you said that you don't continue behaviors that you feel like are punishing.
So for like my preteens, teens that don't want to like, and taking enzymes feels punishing, like how do you approach that?
That is such a good one. I wish I was like a psychologist at this point right now, right? I know just enough to get myself into trouble. Honestly, my instinct goes back to my work with kids with type 1 diabetes. Like taking a shot especially feels like punishment. I probably would pull our social worker in to kind of have conversations and dig with that. Obviously affirm and supporting and validating, absolutely, right? And then from there, I love asking questions like, how does your body feel when you don't take enzymes? And again, depending on your rapport, the answer is probably gonna be like, I'm fine, I don't feel anything, right? Like, okay, well then I'm glad, you know, that's, you're not having any ill effects from that. Hopefully over time, and this is not quick, right? But even when we try to do things quick, I don't know if y'all feel like just here's a handout. Like, does that work? It doesn't work, at least for me. Yes.
Is this one on? Yeah, it is. So this is more a question for me as a clinician. So I work at a transplant center that has very strict BMI criteria. And I really struggle when we basically have to starve the patients to meet the criteria. But it's like, well, you won't get the transplant if you don't meet.
Yeah.
So any advice on that?
Yes, absolutely. So Reagan Chastain, that QR code, she has several articles that she's written. Obviously not lung transplant. A lot of time it's for like gender-affirming surgeries, which are also held by BMI cutoffs. And again, you're meeting your patient where they are and educating, like, we are going to have to take this risk because this is just a really crappy situation and what we have to do right now. Like, I hate that that's the answer, but that's the answer.
Thank you so much, Erin. We will hold off any more questions till the end. Oh, Angel would like to take a picture, so please smile. Say cheese.
Thank you for bearing with us today and all our technical difficulties, I guess. I'm Angel Marie Jones, and I work at Children's Hospital Los Angeles. I've been working in CF for about 6 years, so
So I was correct, just with the last team.
it's okay. So I'm going to introduce our next speaker. Her name is Susan, and she's worked as a clinical dietitian in the CF Center at Nationwide Children's Hospital, Columbus, Ohio, for 30 years. She follows both pediatrics and adult patients at their CF Center. Her specific interests focus on infants in the NICU, status post Mercurium ileus. Merconia, I know, that's not going to come out right. Merconium ileus. It's very tiny. Need new glasses. And nutrition management of pregnancy and CF. Susan participates in the CFF Nutrition Mentoring Program, and she's a preceptor for dietetic graduate students from the Ohio State University. So let's welcome Susan. Thank you.
And then for moving on. I don't think so. I left them at the my chair. Okay. Well, Erin, I appreciate your presentation, and my mind was kind of swirling as I'm thinking, oh, all this education and your
suggestions and encouragement on trust, how can we incorporate that into educating women who are interested in becoming pregnant or who are pregnant? And so as I'm doing this presentation, you can be kind of applying Erin's suggestions and comments. So I appreciate that. I want to thank the NACFC committee members for this opportunity to speak this morning on optimizing nutrition during pregnancy in cystic fibrosis. I have no relationships to disclose related to this presentation. And my objectives today will be to review the nutrition guidelines for pregnant and lactating women with application to cystic fibrosis. I will discuss the nutrition recommendations and therapies for pregnant women diagnosed with gestational diabetes and those with preexisting diabetes. And finally, I will outline some of our CF Center-specific data on our recent outcomes of 34 pregnancies, 34 deliveries of healthy babies over the last 4.5 years. In my review of literature, I came across this article on nutrition and pregnancy for the general population, and I really like the statement here. Although healthy eating and physical activity counseling for adequate weight gain is recommended, the availability of effective support during pregnancy is limited. Most providers and dietitians would agree that preconception counseling is important for any mother-to-be. However, in the real world, very few women receive comprehensive pre-pregnancy advice on nutrition and exercise. However, the women in our CF clinics perhaps have the most opportunity for advice and preconceptional counseling because of their lifelong relationship with the CF team. There was a study done, a survey in the United Kingdom by a dietitian back in the 1990s, and it looked at optimizing pre-pregnancy counseling. And she found that women who did receive pre-pregnancy counseling had better weight gain during the pregnancy and that their babies were heavier at birth. To my knowledge, I don't think another survey has been done, but I was thinking this would be a great project for a graduate student or a dietitian. From a historical standpoint, early studies suggested that women with CF could not and should not become pregnant. The rationale for pregnancy in CF was that pulmonary exacerbation would incur, and that pregnancy would contribute to premature death of mothers with CF. Back in the 1980s, one article suggested that women with CF should be discouraged from becoming pregnant if their PFTs were 80%, below 80%. And for those of you that work with pregnant women, you're probably smiling because many of our patients had much lower PFTs. Fortunately, research by the CF Foundation in the 1990s confirmed that pregnancy in women with CF does not affect their survival. And as we know now, outcomes for mothers and infants have greatly improved over the last 30 years, especially since the era of the highly effective modulators. The registry from the CF Foundation in the year 2000 documented 180 pregnancies. And since that time, there's just been a gradual increase in the number of pregnancies in our patient population until the spring of 2020. And at that point, our patients, several of our patients, adults, had been on the highly effective modulator for about 6 months. And in the spring of 2020, we had patients, about 10 patients announcing that they were pregnant in our clinic. So we were greatly surprised, but we realized how easy it was, much easier for them to become pregnant with ETI. And the increase in pregnancies also correlates with the increase in the median age of our patients. The Academy of Nutrition and Dietetics makes these general recommendations. They talk about appropriate weight gain, consuming a balanced diet, regular exercise, and timely and appropriate vitamin and mineral supplementation, in addition to adequate food intake and food safety. I think that these are very general recommendations, but it's a good place for the dietitian to start with when a patient is in clinic and expresses an interest in becoming pregnant or is newly pregnant. In my review, I've came across these 3 helpful websites on nutrition and pregnancy, and again, these could be referred to the patient or even brought up in clinic and reviewed with them to just emphasize the practical and simplistic recommendations for nutrition and pregnancy. Currently, the CF recommendations suggest, these are the following that suggest better outcomes for mom and baby. A BMI of greater than 19, although ideally we would like 22, an FEV1 of greater than 50%, and the absence of preexisting diabetes. I'll be just choking on this pretty soon. Get everyone here. When dietitians are meeting with our patients, at each clinic visit, they should try to obtain a diet history to assess for calories, protein, calcium, and iron. If the fat-soluble vitamin levels have not been done recently, it's a good idea to get a baseline for those for A, D, and E. And the OGTT, there is a specific protocol with CF. The initial OGTT is recommended between 12 and 16 weeks, and if normal, then repeated at 24 to 28 weeks. Ferritin levels should be checked about 20 weeks gestation to assess for anemia. At our center, we recommend one CF specific vitamin and then one prenatal vitamin, and then supplements as warranted, such as calcium, iron, or vitamin D. Just for in case you're interested, the CF vitamin provides about 200 micrograms of folic acid, and most prenatal vitamins will include 600 to 800 micrograms of folic acid. The dietitian should review the food safety guidelines from the FDA and to also check on WIC eligibility. It's well documented that calorie and protein requirements for pregnancy are increased, and with our CF patients, they are probably going to need even more calories and protein. And this depends on their degree of malabsorption, their pulmonary status, and glycemic control. I thought an interesting rule of thumb was for protein requirements is to look at the pre-pregnancy weight in pounds, divide by 2 for the daily protein goal. So a woman weighing 130 pounds should aim for about 65 grams of protein per day. And this is a well-known weight goal gain chart looking at pre-pregnancy BMI and then the total weight gain. I would have to say now, after listening to Erin's talk, that we need to be more flexible. And certainly my coworkers and I, the patients that we've seen in clinic, some of them start with a very low BMI, about 18, and then surprisingly gain 30 pounds during the pregnancy, while others just really struggle to gain the adequate amount of weight. But it is a good guideline for the patients. There are several micronutrient recommendations that the dietitian should be reviewing, and I've already talked about folic acid. Most vitamin Ds will be adequate, the content, if they're taking the one CF-specific vitamin along with the prenatal vitamin. Interestingly, prenatal vitamins, it's standardized to contain 27 milligrams of iron, but in a gummy, you won't find any of the iron. So it's important for the dietitian to check to see what type of prenatal vitamin the patient is taking. And I have found that when I've even done the preconceptional counseling, I will let those patients know to, if they can tolerate to swallow a pill that's going to contain iron versus the gummy. DHA and EPA are included in some prenatal vitamins, but not all. And the more expensive prenatal vitamins will include the omega-3 fatty acids. In my review, I also learned that iodine wasn't always in prenatal vitamins, and it wasn't until studies were done that showed that iodine deficiency during pregnancy can result in intellectual impairment of the fetus, neonatal hypothyroidism, and contribute to an increased pregnancy loss. So as of probably back in the mid to 2000s, all the prenatal vitamins do include 150 micrograms of iodine. Choline seems to be a newer micronutrient of interest and importance in pregnancy. And I'm thinking back when I had no idea that choline was important when I was pregnant, but it's, more research has been done, and the amount of choline in pregnancy is increased from the standard amount that we need. And of course, it's even higher in lactation. Again, when I reviewed the prenatal vitamins that looking for choline, I found quite a range from 10 milligrams up to 400 milligrams in some prenatal vitamins. And of course, the 400 milligrams of choline was the most expensive, $60 per bottle for prenatal vitamins. So it probably would be easier for a dietitian in clinic to just go over the iron or the choline-rich foods such as egg yolks, chicken, red meat, peanuts, almonds, and lentils. And on one list, Brussels sprouts was included. There are going to be CF-specific nutrition issues for our patients. The phthalates that are used in the enteric coating of the enzyme beads are now deemed safe in pregnancy and lactation. Adjustments in enzymes should be based on malabsorption symptoms rather than the weight gain. And most of us will remember, if you've been pregnant, the nausea and emesis, especially during the first trimester, can negatively impact weight gain even through the second trimester. Women should be encouraged to consume small, frequent meals and maintain adequate hydration. And there's some thought that carbohydrate foods may be better tolerated than protein or fattier foods. Most of our patients experience reflux and constipation even when they're not pregnant, and both reflux and constipation are likely to be exacerbated as the pregnancy progresses. Polyethylene glycol is considered safe for short-term use during the pregnancy. Iron deficiency anemia is also common as the pregnancy progresses, and most of us, I think, have learned that iron supplements may be better tolerated taken every other day than on a daily basis. Our patients with cystic fibrosis are at greater risk for kidney stones due to the fat malabsorption, and certainly this is true, can be true for women who are pregnant. We had one patient who experienced kidney stones during both of her pregnancies. She gained good weight during the first pregnancy, and the baby was about 7 pounds, which was perfect. However, her kidney stones seemed to get worse during the second pregnancy, which was just a couple years later, and she was hospitalized, and a stent was placed, and the weight gain was very poor during the second pregnancy due to just the pain meds and a poor appetite, probably also taking care of a toddler. And her baby was born, the second child was small for gestational age, so it can have an impact on the pregnancy. Women with cystic fibrosis are at greater risk for gestational diabetes. Most of us probably are aware of that. And this is due to lower insulin secretion and higher insulin resistance. I like the comment from the Managing Cystic Fibrosis Related Handbook. It says simply that gestational diabetes occurs when the pancreas cannot keep up with extra demand for insulin. The incidence of gestational diabetes in pregnancies is considerably higher than for women without CF. So women with CF have a 10% to 36% chance of developing gestational diabetes. And this was true for our patient population. We had about 21% developed gestational diabetes. As I'd mentioned before, the CF Foundation has a recommended protocol for screening for gestational diabetes. The initial OGTT is done between 12 to 16 weeks, and if normal, repeated again at 24 to 28 weeks. Women need to be fasting. They will consume 75 grams of a sugary solution, and then a 1 hour and a 2 hour postprandial blood glucose is drawn. In contrast, women without CF, they would just have the OGTT at between 24 and 28 weeks. They do not need to be fasting. They drink 50 grams of a sugary solution, and it's just a 1 hour postprandial. We've learned the hard way not to let the patient have the OGTT done at their OB office or at the maternal fetal medicine department. Even with prescriptions, it seems like they still end up with the standard OGTT. So now we are recommending that all of our pregnant patients come to our hospital lab, and then the orders are in Epic, and they can get the correct OGTT for screening. Preexisting diabetes in CF is very common. 30 to 50% of adult women with CF have CF-related diabetes. And this was also true for our patient population. We had 47% of our patients, pregnant patients, with the CFRD. In the literature, complications of hyperglycemia in pregnancy include macrosomia, neonatal hypoglycemia, and an increased risk of C-section. When we reviewed all of our patients with diabetes and their insulin therapies, we were surprised to see such a variety. Several were on basal insulin with mealtime, basal alone, mealtime alone. 3 of the women had insulin pumps. And then for our gestational diabetes patients, none of them used any kind of insulin. They controlled their glucoses with diet alone. GLP-1 antagonist is not recommended during pregnancy. For glucose monitoring, women, all the women with insulin were able to obtain the continuous glucose monitor. However, as we know, if a patient is not on insulin, it may be more difficult for looking at the time. It may be more difficult for the patient to acquire a CGM. It is recommended that if someone is not doesn't have a continuous glucose monitor, to check their blood sugars about 4 times a day. And diet counseling for diabetes, both the CFRD and the gestational diabetes, we recommend no calorie or carbohydrate restrictions. Sometimes when our patients are counseled at the endocrine office at the adult hospital, they come back and tell us that they've been told to restrict their calories, 1800 ADA diet, and one patient even had some carbohydrates crossed out on a handout. Fortunately, we've counseled our patients ahead of time to ignore that kind of advice and to not restrict calories or carbohydrates, but to match the insulin therapy with their intake. We did have one patient who was diagnosed with diabetes prior to pregnancy. She was not on insulin. She was always sort of modifying her carbohydrate intake, and this was true for her pregnancy. She was bound and determined not to be on insulin, even with my advice to not restrict carbohydrates. Her weight gain at delivery was suboptimal, but that baby weighed close to 8 pounds. So I guess my thought was, you just never know. We do advise patients to limit sweetened beverages, and for most of our gestational diabetic patients, that's what they did. They avoided sweet teas and soda pop in between meals. And then we also emphasize the importance of carbohydrate, protein, and fat for all meals and snacks. Postnatal care, as we know, calories need to be increased during lactation. We were pleased to see that about 50% of our patients did go on to breastfeed their babies. We recommend continuing the prenatal vitamin and one CF-specific vitamin. Most CF medications are considered safe during lactation, and the mental health coordinator will meet with our patients to screen for postpartum depression. This is also usually done at the OB office too. Prior to delivery, it's important to just review with the patient that they can incur rapid weight loss postpartum, and to just stress the importance of taking time to eat and for self-care to continue their CF therapies, especially the CF modulator that needs to be taken twice a day with food. And to just advise the patient that they are going to feel sleep deprived with a newborn. I just will go over a few concluding thoughts before I go on to our CF-specific data. So in conclusion, maternal nutrition is regarded as one of the most important environmental factors influencing pregnancy and for the outcome of the infant. Women with CF are at greater risk for gestational diabetes. We have found that it's so important for close communication with the patient's obstetrician or the MFM department, specifically regarding the screening for gestational diabetes. And nutrition concerns do not end at the time of delivery. Moms need close monitoring during the postnatal period. As I mentioned, in the spring of 2020, when we had about 10 pregnancies announced in our patient population, we decided that we'd better work together to, help these patients and to provide the standard care that we would like to see. So we developed the Nationwide Children's Hospital Pregnancy Task Force, and this included a multidisciplinary team at Nationwide Children's comprised of the CF providers, dietitians, social workers, the adult mental health coordinator, pharmacist, and nurses. Our main goal was to establish close networking with the high-risk obstetricians and endocrinologists at the adult hospital. The objectives also included helping women who are in the pre-contemplative stage or the preconception stage with pre-pregnancy counseling to optimize overall health. And we wanted to ensure that women who are pregnant would receive guideline-directed neonatal care for their CF, which included the appropriate OGTT timing if they weren't already diabetic, weight goals, and closely monitoring pulmonary function. In addition, we wanted to provide postnatal support for breastfeeding and postpartum depression screening and an OGTT follow-up. This chart just shows that we had 34 patients who delivered over the last 4.5 years. 6 are still pregnant. And interesting, when we looked at our average maternal age, it was 27 years, and that just happens to be equivalent to the national average. So you can see here that 47% of our patients were diabetic going into the pregnancy, 21% developed gestational diabetes, and 32% maintained normal glucoses during their pregnancy. We were very interested to see if the glucose status had any effect on the weight gain, which of course is quite common to read in the literature. And not surprising, our patients with CFRD, 50% did have adequate weight gain, but then half of them did not. There were many complications for patients, for several of our patients with diabetes. I think non-adherence was part of that, and just in lower BMIs as well as a lower FEV1 contributed to more CF exacerbations during pregnancy. We were surprised to see that this gestational diabetics, they didn't gain weight very well, and we contribute that to just the fact that they weren't on any kind of insulin therapy. And then the patients with normal glucoses had about 55% that gained weight adequately. So just to summarize, some of the clinical observations that we have made is that preterm deliveries were the highest in those women with the CFRD, and that holds true from the literature. Our data showed that women with CFRD used many different combinations of insulin therapies, and those patients on insulin achieved better weight gain than the diet-controlled patients with gestational diabetes. There was a higher incidence of cesarean deliveries for women with diabetes when compared to those with normal glucoses. Maternal FEV1 in 12 of the 34 deliveries was between 50 to 60%. And despite low lung function, many of them delivered, babies that were quite a good size, And then maternal BMI in 7 of the 34 deliveries was 19 or less, and 4 of the 7 had premature babies, which you would expect. Our average birth weight for 35 babies, we had one set of twins, was 2,900 grams, basically, and that's about 6.5 pounds. This is my literature review, and are there any questions?
Thank you, Susan. Wonderful information. We really appreciate it. And you have so many questions. There's a lot of questions about vitamin A, so we're going to kind of try to combine them. But if you feel like yours wasn't answered, then please let us know.
I did not touch upon the vitamin A in my presentation, mainly because as I reviewed the prenatal vitamins, so many of them had a very low content of the retinol. Most of it was in the form of beta-carotene, as we know, as well as for the CF-specific vitamins. So I never felt like that was an issue. I do think that if a patient is on a single vitamin A supplement, they're going to be advised to stop that during their pregnancy.
Do you know if there's any, like in the works, a CF prenatal vitamin?
Oh, we've thought of that. That would be, I think, a great idea. Yes, we have thought. I'm not sure if the one nurse practitioner who had that idea, if she's reached out to anyone in that field yet.
Great. And I think we have somebody over there.
Hi, Susan. Kim from Columbia, New York. So my question is we often have our patients get the 2 glucose tolerance tests, but they are done by the OB, which is usually through our MFM department anyway, but we do have a lot of difficulty getting the 3-hour done. They're often doing the 1 hour, and I'm wondering how aggressive do you think we need to be with the MFM department getting them to change that?
So your MFM department, are they doing the CF OGTT?
No, so they're doing the 1 hour glucola, but it is fasting.
It is-
not
it is
non-fasting,
fasting,
the
and I've
patients are
heard that.
fasting.
Right,
So I'm wondering, do we need to be very aggressive, reaching out to them and saying we really need to have the 3-hour one? I mean, we are getting obviously positive results with some of them, not all of them.
So when they fail the 1 hour, they go on to do the 3-hour.
Most of them, yes, or we just treat them as if they're CF-related diabetes and refer them to endocrine.
Yeah. I don't know. I guess we've just decided not to do the 1 hour and then go on to do if they fail that, to go on to do the 3-hour. We just do the 2-hour and then refer them on to the adult endocrinologist. And I'm interested, for those of your patients that have developed gestational diabetes, have you encouraged them to go on insulin in any way?
So we have had patients both on insulin and not on insulin. So a very recent patient really wanted to try and avoid insulin, but was willing to go on if she needed to go on, although she did not drink the supplement that we were trying to get her to go on, myself and the DSME dietitian who was seeing her, because the Ensure was making her blood sugar too high. So we were trying to do a higher calorie, higher protein content that I discussed with the DSME provider, trying to make it a little bit more balanced, less sugar. So, but she was afraid to drink it because she was afraid it was going to make her blood sugar too high. So, but at that point, she was in the hospital for like the last 2 weeks before she delivered anyway. So
Yeah. And for some of our patients with gestational diabetes, they're afraid to go on insulin, or they've tried, maybe a few of them have been on it and they've had low blood sugars, so then they've gone off of that. So it is it's a delicate balance.
Okay, we have time for one more question.
Hi, thanks. Is this on? You can kind of hear me. Thanks for the great presentation. I'm Lisa from Toronto. I was just wondering if you think that there's maybe a little bit more wiggle room for our women with gestational diabetes with respect to recommendations around dietary modification, now that we're in this sort of new era with ETI and people are better nourished and perhaps meeting weight gain targets a bit more easily in pregnancy.
I don't think your mic was on, so, but
Try to speak
it was,
I was just wondering if there's room for maybe a bit more dietary modification for our women with gestational diabetes who are on ETI, now that they're kind of meeting nutritional weight gain targets a bit more easily in pregnancy. So maybe can we be restricting carbohydrate a little bit more to help manage their diabetes?
yes, I think definitely, and that's what I think we had 7 patients of the 34 pregnancies that developed gestational diabetes. And, it was interesting that none of them went on insulin, and I'd like to say, well, if they'd been on insulin, perhaps they would have gained weight better. But what I think the overall perspective from studying all these women is that each one is very individualized. It's difficult to see a trend. We have some clinical observations, but the conclusion is, and Sarah and I often, my coworker Sarah's here, we kind of smile and we say, everyone is different, and as I had mentioned, the one patient that refused to go on insulin, even though she had history of CFRD, and her baby weighed 8 pounds, so I guess it goes back to what Erin, was saying, that we have to be a little more, we have to be more understanding and meet the patients where they are. Provide guidelines and suggestions, but not to be judgmental. Yeah. All right.
Thank you.
Thank you, Susan. So cute. Thank you so much, Susan. Our next speaker, who I've had the delight of speaking to via phone and via email quite a few times, She's a wonderful person. I'd like to welcome Steph Hansen. She's a patient advocate from San Antonio, Texas, who's currently serving as one of the CFF's national peer-to-peer ambassadors. And she also serves as on the CFF Adult Advisory Council. So welcome, Steph.
Good morning. You guys like to get started really early in the morning. Start the party early. My lungs do too, so I apologize in advance for the coughing. But I am honored to be here getting to talk with y'all about the emotional, physical, and mental impact of CF in LGBTQIA plus people seeking gender-affirming care. I have nothing to disclose. But I do want to acknowledge that I'm going to be defining some terms and talking about some things that might feel sensitive to some folks. But being an LGBTQIA ally doesn't mean you've got to be an expert. And if you're not an expert after today, that's totally okay. But we're all here in the spirit of learning. And so if you have any questions afterwards, I really encourage you to ask those questions, even if you're not sure that you're wording them correctly. There will be no offense taken on my part. I think that it's just really cool that you guys are here. There we go. All right, so my name is Steph Hansen. My pronouns are she, her, or they, them. And honestly, I also get called he, him sometimes too, or sir. I live in the South. Pronouns are an easy way to affirm somebody's gender. And while this isn't the case for all people who are trans and non-binary, I've got a pretty loose relationship with my pronouns because I identify as gender fluid. You see, I don't identify as one single gender 100% of the time. And sometimes I feel more masculine, other times more feminine, and a lot of the times it's this in-between sort of space. I've thrown up some pronouns on the screen for you to see, but I'm not really going to be going into those. If you would like more resources on those, I'd be happy to provide a great place to educate yourself on those. But now that you know a little bit about me, I would like to go over some terms with you guys so that we are all on the same page going forward. First one's going to be LGBTQIA+. This stands for lesbian, gay, bisexual, transgender, queer, or questioning. That kind of depends on who you're talking to and what that Q means to them. Intersex, asexual, and plus. And that plus encompasses identities such as two-spirit, gender nonconforming, and genderqueer, just to name a few. There are many iterations of LGBTQIA+. You might hear LGBT, LGBTQ, LGBTQIA. They all sort of mean the same thing, but are intended to mean the same thing, but I'm using LGBTQIA+ because it's the most inclusive. After that, we've got the word queer. So queer is an umbrella term used by some folks to describe lesbian, gay, bisexual, and transgender people. But because this word does have a history of being used pejoratively, not every LGBTQIA+ person uses or identifies with this word. I would encourage you to stick to the term LGBTQIA+ when using for a safe and friendly umbrella term, unless you really know somebody and you know that they identify with the word queer. I myself do identify with it, and you might hear me use it today. So I thought it was important to include. After that, we've got transgender or trans, and this is an umbrella term used for people whose gender identity or gender expression is different from cultural expectations based on the gender that they were assigned at birth. Being transgender does not imply any specific sexual orientation, right? So gender identity and sexual orientation, two separate things about a person. After that, we've got non-binary. And non-binary describes a person who does not identify exclusively, as male or female. Non-binary people may identify as being both male and female, somewhere in between, or as falling completely outside of this male-female binary. Now, while many non-binary folks do also identify as being transgender, not all of them do. Non-binary can also be used as an umbrella term encompassing identities such as agender, bigender, genderqueer, gender fluid. And if you're a visual person like I am, I made this to help you understand this a little bit better. So on the left-hand side, we've got the non-binary sort of umbrella. And under that, you see identities such as bigender, gender fluid, or pangender. And on the right, you have the trans umbrella. And usually if somebody identifies as transgender, they typically fall under that male-female binary. So here you see somebody who's trans-masculine or trans-feminine. But in the middle, you see some non-binary people who also identify as trans. And really, there's only two little people in the middle because I am not a PowerPoint wizard. And that's all I could fit in there with you guys still being able to see it clearly, okay? But any of the identities on the left-hand side can fall into the middle. So as an example, I identify as gender fluid. And gender fluidity falls under that non-binary umbrella. I, however, do not identify as trans. So on this Venn diagram, I would fall under the left-hand side. I do, however, know other non-binary people, gender fluid people, or pangender people who do identify as trans. And so in that case, they would fall in the middle. So I hope that helps, clears things up. Okay, after that, we have, under this trans umbrella, we have trans feminine. And trans feminine describes a person who is assigned male at birth, but identifies as identifies as female or feminine presenting. And conversely, we've got trans masculine, which describes a person who is assigned female at birth, but identifies as male or masculine presenting. And then we've got gender-affirming care, what we're talking about today, right? That's a range of healthcare services that help transgender and non-binary folks align their gender identity with their physical traits, right? It's important to note that non-binary people are included in gender-affirming care. It's not just for transgender folks. Under this gender-affirming care umbrella, last umbrella, I promise, we've got top surgery. Top surgery is a surgery that removes or augments breast tissue and reshapes the nipples and chest to create either a more masculine or more feminine appearance for transgender and non-binary folks. After that, we've got chest binding, and this is when a person uses tight-fitting undergarments to give a flatter appearance to the chest. I've seen people use ace bandages and wrap their chest. There's trans tape, which kind of reminds me of kinesiology tape, if you're familiar with that. It's wider and it's more intense. People use compression bras just right off the rack. And at this point in time, there are a variety of binders that people can buy off of the internet with the intent to use for binding. So I'm not going to be going into too much detail on this one today, but I felt like it was really important to include facial feminization procedures. This includes a series of procedures that can reshape the face and its features to achieve a more feminine appearance. This includes, but is not limited to, forehead and hairline contouring, tracheal shave, and brow and eyelid lifts. Then lastly, we've got hormone replacement therapy. And in this context, we're talking about estrogen or testosterone, often called T. And many people call hormone replacement therapy HRT. Okay, so I hope that you guys are all feeling like well-educated LGBTQIA allies at this point. But just a reminder that gender presentation looks different for all non-binary and trans folks. Some people live their entire lives in this gender non-conforming space or gender diverse space, and they never change a single thing about the way that they look. And then there are other people who pursue various levels of gender-affirming care. The experiences that I'm going to touch on today, they won't include all of the paths that a person might take to affirming their gender, but everybody's journey and gender expression is valid, regardless of how many changes they make. So if you've met one trans or non-binary person, that means that you've met one single trans or non-binary person, right? Because everybody's journey and gender expression, it exists on a spectrum. Everyone's different. So I have always been what I like to call a tomboy. I hated dresses. I always fought my mom about getting my hair done. And at the age of 16, I came out as gay, and I spent the next couple of years exploring what that meant to me. Excuse me. Sorry. All right. If you met me in my early 20s, you might have met me when I looked something like this. Look at that hair. But after a childhood of tomboyness, I was finally fitting into this more feminine role that society was placing on me as somebody who was assigned female at birth. Now, I knew looking this way was what other people expected of me, whether they were aware of it or not. But below the surface, there was a pervasive discomfort with the expectation to present as feminine. And there was a lot of fear around how I might present if it wasn't this long-haired, makeup-wearing person. At 24, after a long hospitalization, I was fed up with dealing with my long, thick hair, and I got the courage and excuse that I needed to chop it all off. Now, I claim to others that this was out of convenience because I was in the hospital a lot, but really it was driven by a sense of curiosity about how I might feel with shorter hair. Now, that only progressed as I started dressing in clothes that felt most comfortable to me, like that suit, which were increasingly less feminine by society's standards. Around this time, I also started weightlifting and to put on muscle and taking my enzymes regularly, so that I would look less feminine. But not long after that, the conversation around gender expression really took off and became mainstreamed. And I allowed myself to start sitting with those feelings that had been bubbling up under the surface since I was a kid. Now, I knew that being transgender wasn't quite right to describe my gender identity, but when a well-known celebrity came out when I was 29 as non-binary, I finally gained access to the vocabulary that I always needed to describe my gender identity. On my 30th birthday, I got the courage to come out to my partner and spent the next year coming out to my closest friends. And eventually, I even came out to my CF doctor because that's when I started going by Steph. In a world where I didn't feel comfortable coming out to most people about my gender identity, it was a gift to have a clinician who I felt safe enough to be honest with. And at the time, it was really only my CF doctor, but sometimes all you really need is that one safe person. By this time, I was 30. I was an old lady. My body and my health, they weren't what they used to be in my early 20s or late teens. So I felt really behind in exploring my gender identity. One of the very first questions that my pulmonologist asked me when I first came out to her was whether I was considering binding out of concern for my lung function. Many options for binding can inhibit a person's ability to breathe, and evidence has shown that binding can cause abnormal lung function in healthy adults. When researching binding for myself, I saw terrifying things about other people's experiences binding. I saw things like overheating, chest pain, rib fractures, neurological symptoms, skin irritation, and even bruising. This did not sound like a good time. In fact, in a 2018 study of just under 1,300 patients who bind, 88.9% of those patients experienced at least one of these binding-related symptoms. And because of that, 82.3% of those patients believed it was important to discuss binding with their provider. If my doctor hadn't initiated that conversation about binding that day, I think I would have felt too afraid to or too shy at that point to bring it up. So I'm really glad that she had the confidence to bring it up to me. After we talked, I did attempt binding, but I could never comfortably achieve the look that I wanted because I always felt so short of breath with a binder on. So it was a hard no for my little baby lungs. Now, the evolution of that process was exploring the possibility of top surgery. Now, I had seen what top surgery looked like up close via my transmasculine friends, and I really liked the look achievable. Plus, I think the possibility of never having to wear a bra again sounded incredible. I don't know about you guys, but I think that having to wear a bra as somebody with pulmonary disease should be a crime, like straight to jail kind of crime. So, But I knew that top surgery was going to be a pretty involved surgery. It required drainage tubes and often restricted movement for sometimes months after surgery. And based on my own experience through various surgeries, I knew top surgery was going to be really hard on my body. This is not the face of a girly that does well after surgery. She is not thriving. You know, my lungs, they don't like anesthesia. How would I wear my airway clearance vest with huge incisions on my chest? Would the pain inhibit my ability to cough and clear sputum? And if so, for how long? So, as I've gotten older, surgeries are not just more difficult for me to bounce back from, but exacerbations will often pop up post-operatively. And treatment with antibiotics has become really, really difficult for me due to allergies. So I knew it was likely I'd face lots of complications. After going back and forth on it for well over a year, I decided that top surgery was out of reach for me in order to preserve my physical health. The blow to my mental health was and still is significant, knowing that I'll never be able to affirm my gender in this way. As far as HRT goes, or hormone replacement therapy, which you guys know that, I never felt like this is something like I really needed to commit to long term, and the lack of information about it with CF certainly played a part in my uncertainty around it. I knew that oftentimes trans guys would see a bump in lung function, but beyond that, I knew nothing about hormone replacement therapy. Ultimately, I decided not to pursue gender-affirming care in all of these ways because of what little evidence there was to show how it might impact my lung health in particular, but also my overall health, both in the short term and the long term. I was, and I still am, terrified to compromise my physical health that I worked so hard for, and that fear has outweighed any anguish that I've experienced. Excuse me. But as with many things in CF world, gender-affirming care is not always so straightforward. It can show up in other ways, like it did for me earlier this year. So over the last year and a half, I had linked episodes of hemoptysis that I was having to my menstrual cycle. And in an effort to eliminate these monthly episodes of hemoptysis, I decided to get on birth control for the first time in my entire life. Now, I wasn't super stoked about this at first, but then it occurred to me that stopping menses would actually likely be really gender affirming. So I was like, let's do it. And all was well until about 3 or 4 months in. Now, my OB-GYN had warned me on the front end that this type of birth control might make me gain some weight. But I've got the calorie burning superpower of CF. So I was like, no big deal. It doesn't matter. And, but what she failed to tell me was that I would likely see that weight distribution in all the places that make my body look more feminine. And I realized only after putting on jeans for the first time after a long hospitalization earlier this year, where all I wore was stretchy pants, that while the number on the scale hadn't really changed, my body composition had. I looked in the mirror and I had hips and thighs for the very first time in my whole entire life. The gender dysphoria from this hit me harder and more intensely than any dysphoria had thus far. Now, I didn't touch on this earlier, excuse me, but gender dysphoria is defined as a deep sense of unease and distress caused by the mismatch of gender assigned at birth and gender identity. Dysphoria can feel or present differently for different people. I recently polled a bunch of my good non-binary and trans friends trying to get them to explain how dysphoria felt for them if they were explaining it to somebody who hadn't ever experienced gender dysphoria. And I got words like depression, grief, anxiety, hyperfixation, and even heartbreak. Sometimes dysphoria is a blaring alarm, and sometimes in my head, and sometimes it's like constant static in the background of your day that just doesn't go away. You know, I've looked at my face after being on high doses of prednisone and not really recognized myself because my cheeks are so round or so puffy and my face is so round, and I've watched as My body has accumulated scar after scar due to surgeries and procedures. And while those experiences are uncomfortable, the distress from those experiences has never come close to the anguish that I felt due to gender dysphoria. For me, it is the relentless feeling that something is wrong. It sort of occurs to me the way that physical pain occurs to me. You have these like distress signals sending things to your brain. It's like, hey, there's something wrong in your body. You got to take care of it right now. But when you're in pain like that, you can get frantic. And if you are left in pain like that for long enough, it can make you desperate enough to do anything to make it change or make it stop. And that's the point I reached this summer. Now, I knew I couldn't change the weight distribution. Oh, no. Yeah, me. Huh. That's the point I reached this summer. I started losing weight by any means necessary without giving a second thought to my health. This summer was a tough one, though, because I was really sick and I couldn't increase my physical activity. So I cut my calories by about half. I've been nervous to say that in front of you guys. Luckily for me, though, I trusted my doctor enough to be honest with her about my intention to lose weight, even though maybe I wasn't super honest about the way I was doing it. And there was nothing that anybody could do or say to me at that appointment that would change my mind. I didn't want to be educated or made to feel bad about something that felt absolutely vital to me. And as we talked, I could see her concern, but she didn't try and convince me to stop. She talked about parameters around how I could achieve my weight goal, but there was nothing but kindness and understanding from her. Along the way this summer, I found other ways of coping, mostly wearing long and loose-fitting clothing, which in the height of Texas summer is super uncomfortable. I would not recommend it, and it's not something I want to do again. Trying to affirm my gender in a body that is so heavily medicalized it's been a discouraging and it's sometimes a devastating process. Because of my CF, I feel like I already spend so much of my time just trying to get my body to stay stable that there never seems to be a good time to make big changes like this. As it stands, I'm still weighing the pros and cons of getting off of birth control and facing the possibility of regular episodes of hemoptysis coming back. It's exhausting to think about the impact that this might have on my body, and I'm dreading the doctor's appointment where I have to make a definitive decision about this. For the first time ever, though, I'm considering affirming my gender as my top priority because that blaring alarm that I mentioned earlier, it's been going off in my head for months. I know that if I opt to stop birth control, my team probably won't be super stoked on it, but I never fear that I won't have their support to make this change as safely as possible. I think oftentimes the hardest thing about transitioning are the expectations that other people put on you. There's the expectation to present with the gender you were assigned at birth, or even to present like you fall within the male-female binary. And when it comes to trans and non-binary folks with CF, I think this can include the expectation to put your CF or your physical health first. But for so many, that's just not possible. To me and so many other trans and non-binary folks, when you finally reach that point of seeking gender-affirming care, it often doesn't feel like a choice. It feels like the only way to keep moving forward. I know that I'm not alone in my experience of trying to balance my health and affirming my gender, because recently I was talking to my friend Kyle, he's a trans guy with CF, and he shared his experience about binding as a teenager before getting top surgery. When his pulmonologist would ask him about how long or tightly he'd been using his binder during the day, Kyle would often lie. In fear of being judged by his pulmonologist, or worse, having that binder taken away by his parents as a result of telling the truth, it felt absolutely essential to him. You know, in that 2018 study that I referenced earlier, one conclusion that they came to was that low rates for seeking care for binding-related symptoms was less likely driven by discomfort around chest examinations And it was more likely due to the lack of access to providers with whom patients feel safe and comfortable. Author Charles Feltman has a definition of trust that I really love, and I think that it's relevant to think about here from the perspective of a trans or non-binary patient. He describes trust as choosing to risk making something that you value vulnerable to another person's actions. And he also defines distrust as what is important to me is not safe with this person in this situation or any situation. I don't know about y'all, but this sounds similar to the internal dialogue that I have when I'm thinking about how open or honest I'm going to be with somebody, especially around my gender identity. Recently, when talking to another trans guy with CF, his name is Rowan, he told me about how he's been really open about his transition. He even wrote a blog post about it a couple years ago. He said that he still has people, especially young people, finding him on social media regularly to ask him about his transition and even ask for medical advice, which he politely declines giving. But they reach out to him because they're often too afraid to bring it up with their own care teams. Trust takes time, right? I think this can be especially true for trans and non-binary folks as people who face discrimination and a general lack of safe spaces. But when we as patients are consistently met with psychological safety from our clinicians, that trust that's built enables us to take risks and open up ourselves about what's most important to us. Now, I have only ever explored my gender with the freedom of being an adult, but I have been a young queer kid who wasn't always safe at home. And when I think about the ways that my PD team created safety for young queer Steph and how they treated her with dignity, it set the standard for my future relationships with clinicians because I knew from then on that spaces like this existed for people like me. Now, I only know that I can tell my team hard truths now and risk being vulnerable today because they have demonstrated and reinforced that safety and trust time and time again. I'm really cutting it close. So, in conclusion, there's a deficit of information around seeking gender-affirming care for trans and non-binary folks with CF and how our CF might play a part in that transition. While not every patient is in a space to be able to be open and honest, I can say from experience that even having one single person to talk to or work with can make all of the difference, even if that person doesn't have all the answers. The desperation to affirm our gender as trans and non-binary people with CF can lead some folks to do some things that maybe aren't super safe or great for their health. But to know that we are safe from judgment, are going to be able to be treated with dignity, and have the ability to enter into a collaborative process with our CF care teams, I think that has the potential to prolong and save trans and non-binary lives. Thank you.
Thank you, Steph. Stay up here, stay up here. Steph, stay up here. Thank you, Steph, for that wonderful presentation. You totally rocked that suit. And yes, let's talk about how we can make bra wearing a crime. But on a serious note, and start out with the first question, it sounded like you definitely have a very safe and an understanding team. And I know many of us want to be that for our patients. So what is a good way to signal safety to LGBTQIA+ patients?
So especially if you're dealing, I think, with patients who you might not be sure if they're LGBTQIA+, or even if they are. I recently went to a center that is not my center last year, and there's always a little bit of apprehension when you walk into new clinical spaces. You're not sure how they're going to treat you, especially if you're openly queer. And one of the first people checking me in was wearing a rainbow lanyard at the pulmonary clinic. And that immediately put me at ease. I think other small little things that you could do are, a rainbow flag on your badge, a pronouns pin with your pronouns on it. That signifies, at least to me, this is not one size fits all, but that at least signals to me, and I know several other, like many other people, that like, hey, this is a person that I can have a conversation with about my gender identity or sexual orientation.
Anybody else? So otherwise, I will put another question. Has cost ever been a factor in your decision to not pursue gender affirming?
Yeah, that was definitely a factor when I was considering top surgery. I knew my insurance was likely to not cover top surgery. And then, you know, a lot of people, a lot of trans folks crowdfund, like GoFundMes, do GoFundMes. And that was not an option for me. That's sort of something I keep in my back pocket for the transplant thing later on down the road. I don't want to have to use that more than once. So that just was a hard no for me. And saving for top surgery was going to be something that took a really long time. So it was definitely a factor, but my health, my physical health was more of a factor for sure.
Okay, one more question. What should I do if I accidentally misgender a patient?
This is a really great question. If you're unsure of a patient's gender, or if you know their gender and accidentally misgender them, again, not one size fits all, but my suggestion for the best approach is to quickly acknowledge that you misgendered them, a quick, I'm sorry, and then move on quickly with the conversation. Often what happens with queer non-binary folks is somebody will be like, oh my God, I'm so sorry. I'm so sorry. I'm just so sorry. And then it puts it back on us to be like, it's okay. Don't worry. No big deal. So just a quick acknowledgement that you accidentally misgendered them, and then move on and just try not to misgender them again.
Question?
Hi. First, I want to say thank you so much for your talk. I think you really opened a lot of eyes here, and so thank you for sharing your story. I work at Oregon Health Science and University, and I'm in the adult care, and we have a lot of patients that are either coming up from peds or just transitioning to our center that are either going through transition, trying to figure out their identity. And I think a lot that brings with that is a lot of mental health issues. And I can think of a lot of our patients that are really struggling. And so if you're open to share some ideas to help them get through those difficult times that we could share with them when they're going through like a really bad depression or trying to figure out who they are in this world.
Yeah, well, I mean, again, I can sort of speak to the way my pediatric team created safety for me as a young adult. And, you know, I used to hate going to see my pediatric pulmonologist, but then as I got a little bit older, it was actually such a relief because I knew that it was one of the only safe spaces that I had. And obviously, I think, you know, of course, if these patients are able to see mental health professionals outside of clinic, that's the best course of action for sure. But, you know, it made a huge difference to me. I went from like, my mom used to pick me up from school and she'd say, okay, we're going to go see your doctor. And I'd burst into tears because I didn't want to. And then when I got a little bit older, it was such a relief to be able to see these people who created such a safe space for me outside of sort of the tumultuous area of my home. That it was just always a relief to see safe people, and that kind of kept me going. So I really encourage you to continue to try and foster an inclusive and safe space for your patients while they're with you.
Thank you, Steph. That was wonderful. We put the QR code for the feedback for next year's NACFC, so we would love it if you guys would take that. We want to thank the organizers for inviting Angel and I to moderate this session, and thank you all for putting up with all the technical difficulties, and have a great conference.